4, 3, 2, 1. We are live.
Yeah.
Rahul sir?
Yes, you can go ahead.
So, good evening all. I welcome you all in the another master class in hand surgery from ROSA and Jaipur Hand Surgery Association. So today this master class is on difficult problems of forearm access. And we have among the faculty Dr. Abhijeet Wahegaonkar from Pune, senior faculty member Dr. Purnima Patni, Dr. Rajeev Gupta, Dr. Amit Mittal, Dr. Rahul Garg, and Dr. Yogesh Sharma. For today's moderator is Dr. Amit Vyas and Dr. Narender Saini. I would like to invite ROSA President Dr. Arun Vaishya to officially say a few words to start this webinar. Dr. Arun, please unmute yourself, sir. Dr. Arun Vaishya, sir, please unmute yourself.
Yeah. So, thank you, Rahul. Good evening, everybody. Welcome to this ROSA webinar, and I welcome all the faculty members who have joined in, and I'm very thankful to all of them for giving their inputs in this ROSA webinar of the forum. I would like to congratulate Dr. Amit Vyas for inviting me for this and inviting the faculty and enlightening the state on this topic. And I would request to continue and start this meet. Thank you.
Thank you, Dr. Arun Vaishya, sir. Now, not taking much of the time, I will hand over mic to Dr. Amit Vyas, who will introduce the faculty and start the session. Over to you, Amit.
Good evening, everybody. In our series of master classes in hand surgery, today we are going to discuss the difficult problem of forearm access. As this topic is very less discussed in both orthopedic and hand surgery conferences, and if these problems are not dealt properly, then it may lead to restricted range of movement at pronosupination as well as DURJ movements. So today we are going to discuss these problems, and what will be the order? First, I will share one case, then Dr. Abhijeet Wahegaonkar will give the overall scenario, how to deal these problems, and then further we will discuss the cases. So I am starting with case first. So what we will do, I will share my screen, then I will ask our esteemed faculty by their name, so there will be no confusion, and then they should unmute themselves and then speak. So I'm starting with first case.
Any questions from audience can be given on the OrthoTV or YouTube. So the faculty will answer those questions. We'll take one by one all the questions.
Yes. So welcome, Dr. Abhijeet Wahegaonkar, sir. Wahegaonkar, sir.
Hello, good evening, everyone. I'm very sorry I'm late. I was just stuck up.
No problem. We have started meeting, and after discussing one case, then we will come to your topic.
Sure. Thank you.
So, hope my screen is visible and I'm audible. So I'm presenting this case of 30-year-old right-handed teacher. He had a road traffic accident when suddenly a dog come in front of his bike and he fell down on his hand, and he had uh, this he has this injury. uh, uh, may I ask to Dr. Amit Mittal, could you describe the injury pattern? Dr. Amit Mittal.
Yes, I could see this X-ray.
Yeah.
So it's a AP view and some lateral view. So if I see that the elbow joint, there is also there is a fracture and the dislocation, basically dislocation of the radial head, probably anterior, I think so. There is a fracture of this proximal shaft of the ulna, comminuted fracture, and ulnar styloid fracture distally.
Yes.
I think so. And soft tissue injury, I think it seems to be normal. Not to know any open injuries there.
Dr. Rahul Garg, sir, you want to add something or you want to? Sir, please unmute yourself. Please unmute yourself.
There is a component of radiocarpal subluxation also. I'm not able to exactly lateral view. I'm not able AP view. As I can see, there is a overlap of scaphoid and lunate. I'm not sure actually if lateral view is not completely including the wrist joint. So
Yes.
I do not know clinically or whether the distal radiocarpal joint is also involved in subluxating injury with fracture of the ulnar styloid.
Yes. There is a very good point that we should take full length X-rays of this. W, sir,
Yes.
you want to add the things or?
No, I think all the points have been covered. There seems to be a fracture, kind of a Monteggia fracture dislocation, and I'm not very sure from this X-ray, but there looks like there is an ulnar styloid fracture, perhaps. But other than that, I think all points have been covered so far regarding the X-ray findings.
So, sir, how you will approach for these fractures?
So you're asking me, should I answer?
Yes.
Okay. So there is something called as a Mubarak's line, which is something, a line that connects the tip of the olecranon. If you draw a line from the tip of the olecranon to the styloid, the ulnar styloid process in the lateral view, the ulna should be in one straight line. And it is important to restore the anatomy in reference to the Mubarak's line. And once you do that, the proximal radio-ulnar joint usually falls back in place. Now, considering the fact that there is comminution here, it may be a challenge, but this is something which should never be treated by nailing. There is, people are tempted to nail these fractures, so they should never, ever be treated by nailing. This has to be plated. If required, you should not hesitate to use bone graft, especially to address the combination, try to get that. I'm sure the butterfly fragment might be large enough to be able to hold an interfragmentary screw. And once you do that, I think the proximal radio-ulnar joint should fall back into place. And that should be good enough to restore the anatomy. And after you fix that, you would assess the DRUJ stability, and based on what you find on table, you would take a call. Yes. That would be my approach.
Okay, thank you, sir. So it's a good point that we should try to restore the Mubarak line. But unfortunately, this patient presented to me at 6 weeks with this X-ray condition, and as his range of movement was not improving, with intensive physiotherapy. And he presented with jog of movement at elbow with forearm is locked in supination. Dr. Yogesh, Dr. Yogesh Sharma? He's not. Dr. Rajeev Gupta, sir?
I think looking at this X-ray, the fracture osteosynthesis. I think this X-ray is proper now. I think still radial is out. It not reduced. That's why the movement at the elbow is not there.
So
And the non-union site at non-union at the fracture site.
it is only 6 weeks.
Okay, that's a gap.
Yeah, gap is there. Okay. Madam, Purnima Patni, madam, would you like to comment on at this stage what's next, what we should do? Because now it is 6 weeks, elbow range is not improving, and it is already 6 weeks, and patient is having stiff elbow. Madam, please unmute yourself. Please unmute yourself. Yes.
Firstly, this extensive physiotherapy जो बोलते हो ना आप लोग,
yes,
that frightens me somehow. You know, when the forearm and elbow is concerned, that's a scary thing.
Yes.
Secondly, the radial head is not reduced.
Yes.
And personally, even the ulna, to my mind, would need a revision of some sorts. It is not united. So again, we don't have a full length X-ray also in this. That also is, even if it's a check X-ray, I would prefer a full length X-ray.
Full length X-ray. So it's a very valid point raised by madam that as anatomy is not corrected, so we can't expect movements. So intensive physiotherapy is not advisable at this present. Even in cases of elbow, we usually prefer, it is taught to us that gentle elbow mobilization should be preferred. So W sir, Wahegaonkar sir?
Yeah.
What will be your approach at this stage?
So, like I said at the get-go, how long is it now since the index surgery?
6 weeks.
6 weeks. So it still might be possible to restore the length of the ulna. What is the status of the DRUJ? Do you have an X-ray of the DRUJ?
I don't have X-ray, but DRJ is okay, sir.
Is okay.
Yeah.
You know, because see, like the X-ray, the previous X-ray also showed some suspicious aspect of the TFCC. I mean, the styloid. I would very much be interested in looking at the DRUJ. But nevertheless, granted that you know, the DRUJ is okay, it is of paramount importance to restore the length and the anatomy of the ulna. And it is only by virtue of doing this that the proximal radioulnar joint will fall back in place, hopefully. But there is a very, you know, there is a good possibility because of the fibrosis that this may not be possible. Radial head resection is not an option. If the radial head does not fall back in place, there is a speed procedure where you use a triceps fascia to reconstruct a sling around the radial neck and try and reconstruct a restraint similar to the annular ligament by which you can get back the joint in place. But again, the results are often compromised if you have to resort to these reconstructive procedures. Your best bet would be to try and restore the anatomy of the ulna, the length of the ulna. The angle has to be corrected, and that is the only way by which you can, you know, deal with this problem.
Yes, you correctly said that as the butterfly fragment was large and probably as it was removed, so there is decreased length of the ulna, so radial head is not coming at its place. place. So I opened again it, removed the implant, restored the length of the ulna, and then used bone graft. And now the radial head came into its place. So I fixed with the radiocapitular wire temporarily.
Why did you put a wire there?
Sir, because it was already complicated case, and I didn't want to lose my reduction. So especially in these type of cases, I usually put a radiocapitular wire for initial 3 weeks. But it's a good idea that you can restore the annular ligament with the triceps fascia.
Do you have an X-ray after removal of the K wire?
Yeah, I have. So usually you don't prefer to put wires?
No, I don't.
Dr. Amit, can I interrupt you?
Yeah.
Can I ask you why was the plate bent here?
Sir, just to maintain the length of the ulna, because it was lifting up.
Okay.
Anyone wants to comment on this at this stage?
And
Dr. Narender?
Yes.
It was also grafted.
May I say something?
Yeah, please, sir.
May I say something?
Yeah, please, sir.
So if the radial head is getting lifted off, it means that the ulna is still not the way it should be. And if you really look at the lateral view very critically, the radial head should be in the sigmoid notch and in front of the capitulum. And I'm not able to make I'm not able to see that very clearly from this X-ray and from the image. But if it is jumping off, I don't think that we can rely only on a K wire and then the ensuing fibrosis to stabilize it. So that's my thought. It should be stable enough, or it should fall back in place by virtue of addressing the ulna. And that's the reason why I asked. Do you have any post-operative images and all that you can share?
Yeah, I have. But this point is well taken that I would have done more lengthening of the ulna. So probably it radial as by gaining the ulnar height, radial head will be reduced well.
Dr. Amit?
Yeah, please.
After reduction, how much is the range of movement of the elbow? Once the radial head get reduced, what was you think is the cause of that restriction of elbow flexion extension? The radial head only, or some contracture also you find, or you have opened some radiocapitular joint something?
Sorry, I'm getting your point. Pre-operatively, there was restricted range of movement. You were asking about that? Hello?
Per op, after reducing the radial head and plating the ulna,
okay,
what range of movement you have gained?
Okay, I'm coming on that. So as W sir asked, this is X-ray at 3rd month. Ulna has started uniting, and now initially I was also have suspicion. Then I removed the wire at 3 weeks and started mobilization. And this is the X-ray. Sir, you were asking about the X-ray without wires.
Yeah. Good job.
Okay. And as Amit asked about range of movement, I was able to achieve this much range of movement. Still last 20-30 degree of elbow extension is restricted, but it is quite improved from the last stage. And the patient has gained supination, but pronation is restricted. How to improve this pronation and what can be the cause of restriction of pronation? Narender Saini sir, can you comment on this?
Amit.
Yeah, yes.
You see, restriction can be because the radial head was reduced forcibly. It was not coming by itself. It was held there. So the soft tissue envelope around it and the fibrosis there can cause some restriction. But I think this is a fair movement as far as the fracture is concerned. And the type of injury and the duration in which you have entered.
So,
Dr. Amit,
yeah.
Can we go back to the last X-ray, please? Just before this.
Yes.
In this lateral view, are we getting any heterotropic ossification sort of finding or this one?
This one.
Can this contribute to your restriction of pronation?
Pronation, I not, but it may be cause of restriction of.
Hello.
Yeah. Did you use graft while putting this plate?
I used graft to restore.
Graft from?
Iliac crest.
Iliac crest. Okay. Right.
Because I had to restore the ulnar length.
Right. It was a tricortical graft.
Yes, to get the length and then cancellous graft all around.
Okay. Envelope. Okay.
Yes.
Right.
So,
quite good.
Thank you, sir. So I think the message by this case that restoring the Rahul Katta, sir, please.
Go back to the previous X-ray. I have few questions to all the faculty members. Good case. What I understand is the two key points for such kind of fractures: the restoration of the ulnar length and the angulation, correction of the angulation at the fracture site. Correct? And by doing these two things, the radial head would fall in its place. So anyone can answer intraoperatively, apart from the reduction of the proximal radio-ulnar joint, any method to check that you have achieved a perfect ulnar length in case of communications? Any key point intraoperatively? You have achieved a perfect ulnar length.
To see in the C-arm lateral view, a dead lateral view, and doing a full flexion. If your forearm, anterior part of the forearm touches your anterior part of the shoulder, arm, I think that should give us an idea. The radial head is well reduced and we are getting 100% flexion, achievable flexion.
So, if I may interrupt, I'm actually annotating the lateral X-ray. I've drawn this green line.
So again, there is angulation in
so this angulation is pretty critical, and if I were to extend this line proximally in the same thing, you can see that it is not touching the tip of the olecranon. And that kind of is, so that is the Mubarak's line I'm trying to reproduce here. And there is an angulation. I think one of the reasons that the movement might be reduced, I'm not sure what's up, but at this stage, even a CT scan would give us a little bit of information as to what's happening. So this is, when you're doing a revision surgery, this is especially important to have the Mubarak's line restored and to have the implant also in a manner that will allow you to do it to the best possible. So to be very honest, I mean, if I were to look at this, I would perhaps not hesitate to resect the ends of the ulna so that I could get a much, kind of a size matched bone graft into the defect, so as to be able. So my concern will not be the defect, but more so restoration of the length of the ulna and correction of any residual angulation.
Okay, it's a good point. And sir, is any role of distraction of ulnar ends to get radial head to reduce, and on that
And yeah, temporarily, yes, intraoperative fixator distractor may be applied. These are very standard AO principles that can be done.
Yes.
And they just help you with reduction and maintaining the length while you're fixing the defect.
So,
Amit, can I ask a question?
yeah, please.
This is 6 weeks old. If you get this patient after 3 months, what would be the management? You are going to save the radial head, or you are going to exercise? You will go exercise the radial head. Is there any indication of excision of radial head in old cases?
Madam, could you comment?
No, I would not.
W, sir? Wahegaonkar, sir?
Thank you. Hello, sir. Yeah, tell me. I'm sorry.
Dr. Rajeev Gupta has asked.
Yeah.
Suppose this case.
At 3 months.
Yeah, at 3 months.
I'll refer him to you.
I will refer you again.
No, these are not. So to be very honest, the lighter aspect of it apart, you really need to counsel the patient. These are not easy injuries to deal with. Again, at 3 months, my endeavor would be to restore the length of the ulnar. It is not easy to get the radial head back. At this time, doing the speed procedure would be much more pertinent using a triceps fascial sling. There are reports that it does work in a certain number of cases, but again, I want to reiterate at the cost of sounding repetitive, that restoring the length and eliminating the angulation of the ulna is very important, and that is the only way by which you can restore function. At 3 months, I would also be very keen on getting a CT scan done. I would do an opposite side X-ray. There is a role of 3D printing to do your bone grafting and reconstructing. So these are all things that you may want to utilize to your advantage when dealing with these problems.
Amit, if we are planning to preserve, how much movement we can expect around the elbow joint in such a late case? Still, there is chances of myositis is there. So, how to counsel a patient regarding the movements and while preserving the radial head? This is what.
So, I wouldn't be too concerned about the myositis because they're pretty away from the elbow joint. But suffice, I mean, there is a possibility, but I don't think it's much of a looming concern. You would want to get your alkaline phosphatase ESR CRP done. That itself can give you a fair idea about what's happening with the myositis aspect of it. I would be very wary of promising the moon to the patient. I would say that my endeavor would be to get him a functional range of movement. But a lot of times, these patients who have had multiple surgeries without, getting a reasonable outcome may proceed to the end stage surgery, which is a single bone forearm. So you have to really temper your surgical enthusiasm with the realistic, actualities as far as the function and the movements come back, and more so in rotation rather than the elbow movement. So you need to really keep your patient's expectations grounded, and even your surgical efforts, or do not promise the moon to the patient. That's very important in my books.
Okay, thank you all for participating. Now I will invite Dr. Abhijeet Wahegaonkar for his talk on how to approach the difficult problem on the forearm axis. W sir, please share your screen.
Yes, sir. Thank you very much once again to everyone at my second home, Jaipur, and thank you so much for the opportunity to be back with the typo here. That should have been me. So my task today is to talk about SX low-density injuries, and I do not have any conflict of interest regarding this presentation. So let us begin with a case in point. This is a patient. I'm sorry. This is a slide from the previous, but we'll begin for this is a young gentleman who had a history of fall. And are you able to see all these X-rays here clearly? So he had a history of fall, and he was, I think, this is approximately 7 years ago, and he was seen elsewhere, and this is the injury he had. Can someone please read the X-ray and tell me what's going on, please?
Okay, so I think it's an X-ray of elbow, AP and lateral view, and in the AP view, in the bony shadow, it seems that radial head is fractured, and on the lateral view, you can confirm it, and rest of the thing in my eyes looks okay.
Okay, and how would you manage this, sir?
Sir, I will ask for CT scan of this elbow and full length X-ray of the forearm.
Okay, so unfortunately the full length X-ray was not available at that point in time, and this is the CT scan that was available here, and this was done for him. Okay, a radial head replacement was done. Any critical comments?
Is the reduction okay with the, is it congruous with the capitulum?
Difficult to say from this X-ray, but for 7 years he didn't have any problem, ma'am. His elbow range of motion is full, his pronosupination. So I think you would say that it is congruent with the capitulum. Perhaps this is a hyperflexion elbow, so difficult to make out. But my concern here, especially on this extension view, lateral view, is that, so the biggest problem with radial head arthroplasty in a scenario where there's trauma is either understuffing or overstuffing. Understuffing will cause valgus instability, overstuffing will cause chondromalacia of the capitulum, and then pain and an impaction kind of a syndrome. And if you were to see this lateral view here as well, there is some lysis around the stem, and there is, I mean, at the get-go, there was some understuffing. So this patient came to the clinic just last week, in fact, complaining of pain along the forearm and the ulnar aspect of the forearm. And this is a short video clip. This is the unaffected or the non-operated site. And you can see that on the affected or the operated side, pronation supination is free. But look at what is happening with the distal radio-ulnar joint. You can see that he's not wincing when I'm doing that. It's not painful, but he has this dull, aching pain and inability to do strenuous work. So with that introduction to, this topic, and I'm sure by now you must have all imagined that this might have been an Essex low-pressure injury to begin with, wherein there is a longitudinal injury to the forearm axis leading to this kind of presentation. So here is a history. Way back in 1946, this paper, which was published in the British Journal of Surgery, talked about DRA dislocation, but they perhaps did not recognize what's happening to the proximal aspect. And it was later in 1951, a few years down the line, when Essex Lopresti published an article that now bears his name and carries his name, which is synonymous with his name, and that was fractures of the radial head with distal radio-ulnar dislocation. And he presented 2 cases in this particular paper. So what are complex lesions of the forearm? We have either the Galeazzi variant, we have the Monteggia variant, and we have the Essex Lopresti variant. And let us try to understand what is happening. So whenever there is a fall in an outstretched hand, here is a schematic diagram showing you the the forearm axis with the elbow joint. So when there is an axial loading of the forearm, and when the radius fails, and there is a fracture and there is a dislocation of the distal radio-ulnar joint, this is the Galeazzi mechanism. Whereas in Monteggia, like we just saw with Dr. Amit Vyas's presentation, there is a fracture of the ulna and a dislocation of the proximal radio-ulnar joint. So this is the Monteggia variant. Whereas in the Essex Lopresti, there are three components: of fracture of the radial head with a disruption of the interosseous membrane and a disruption of the distal radio-ulnar joint. So essentially what is happening is that when there is a fall on an outstretched hand, the forces are transmitted in a manner where there is a fracture of the radial head, and at the same time, there is a longitudinal tear of the interosseous membrane, and thereby leading to a problem of the distal radio-ulnar joint, because we now recognize that the distal oblique band of the interosseous membrane plays a very vital role in the stability of the distal radio-ulnar joint. So it's a pretty rare injury, accounting from anywhere between 0.3 to 5% of all fractures of the radial head. And clinical diagnosis, clinical examination, the diagnosis is based on clinical examination, images, and very, very important to take an X-ray of the elbow as well as the wrist joint, and always bear in mind the possibility of an Essex Lopresti variant, especially if there is a radial head fracture. The DRUJ must always, always, always be examined. So patients present with pain around the elbow and the radial head, there may be pain in the wrist and the distal radio-ulnar joint, but these are usually late presentations, just like we saw in that case. There may be a reduction in the arc of rotation and ulnar impingement because of proximal migration of the radius. And the caveat is that this is very often missed at initial presentation. So I hope that this topic, and today our deliberation on this topic will serve as a reminder to our junior colleagues and everyone out there who are listening, to have a differential of this at the back of your mind whenever you're looking at forearm injuries. So when we talk about imaging these injuries, essentially X-rays are of paramount importance. You may even take some stress X-rays, an MRI or an ultrasound. Ultrasound has a definite role in diagnosing the interosseous membrane injuries, especially if your sonologist is an astute sonologist with experience. You need to talk to these radiologists to tell them that you're thinking of these injuries. There is a classification that has been described in literature by Edwards and Jupiter, which talk of type 1, type 2, and type 3, and they kind of also give you a guideline as to what can be done. In type 1, there is a reconstructible fracture of the radial, like a Mason 1 kind of an injury. Whereas in type 2, there is a non-reconstructible fracture of the radial head, like a Mason type 3. And in type 3, there is a chronic injury with proximal migration of the radius. So the problems are that we are faced with three problems. One is the treatment of the radial head fracture. We are looking at an disruption of the interosseous membrane, and the DRUJ also poses a challenge in dealing with these injuries. So let us take them one by one, talking about the fracture of the radial head, whether we should reconstruct, resect it, or use a prosthesis. And to be able to determine what might be the best way to deal with it, you do the radius full test, wherein the longitudinal instability can be tested in the operating theater under anesthesia. So after exposure of the proximal part of the radius, a bone reduction clamp is used to grasp the proximal radius, and a longitudinal pull is applied manually under fluoroscopic control before and during after pulling. So if there is more than 3 millimeters of proximal migration on the radial pull test, this does indicate a disruption of the interosseous membrane, and this is 83% sensitive or specific. However, if there is more than 6 millimeters, it is 100% sensitive or specific for a tear of the interosseous membrane and the triangular fibrocartilage ligament. So this is a very important test that you can use in determining the extent of the injury. Now, reconstruction in these procedures, the reconstruction of the radial head or the fractured head is often difficult in congenital fractures, and a lot of times secondary surgery may be necessary, and you begin with reconstruction of the radial pillar. And the third option is that of performing a prosthesis, wherein radial stability is restituted. And when you look at the elbow joint biomechanics, the ulnohumeral joint is that for movement and stability, whereas the radiocapital joint does provide valgus stability, but more so for load transmissions from the forearm axis onto the arm axis. So usually prosthesis, when used judiciously, and if you have the correct options of doing a good radial head replacement, it does provide good outcomes in a select cohort of patients. Again, you have to understand that this is a relatively rare injury, so our understanding is pretty limited from literature regarding what is the best treatment for this. So resection of the radial head may be a solution for the problem of the proximal radio-ulnar joint, but then this usually results in a bigger problem at the distal radio-ulnar joint. So what happens after resection? There is a radial-sided instability, there is a consecutive relative ulnar advancement, and there is an ulnocarpal impingement. So all of these, so you're compounding the problem by a radial head resection. So whenever there's a fracture of the radial head, you should try to reconstruct it whenever possible with whatever methods you have, or you may want to resort to a radial head replacement. So here is what he concluded in his paper. Recognition of the injury is important because after excision of the radial head, the DRUJ will be unstable and will aggravate the problem and will be a recurrent problem in spite our efforts to prevent. So way back in 1951, he made a very astute observation that we all need to really bear in mind when you're dealing with these injuries. Now, coming to the second aspect of the injury, and that is the intraosseous membrane. What do we do about it? So there is really no specific treatment for it. And there have been several attempts that have been described in literature wherein they have tried to reconstruct the anatomy of the biomechanics of the intraosseous membrane. So if you look at the intraosseous membrane, it has kind of a Z-shaped mechanical pattern where it allows a little bit of longitudinal axial motion between the radius and the ulna. And then you try to reconstruct it using this Achilles tendon graft or a patellar BTV graft, and they have all been described in literature. And multiple biomechanical studies have also been done to assess if this really works. And here are some schematic diagrams and some cadaver dissections from the literature that has been published. So this particular aspect of the intraosseous membrane, which is corresponding to the insertion of the pronative teres onto the ulna, is something that you need to reconstruct. And to be able to do that, they have used several different techniques, but there is nothing that is really a robust and a reliable and a reproducible kind of an option that we have. The third component is a distal radio-ulnar joint. And there are multiple ways that this has been addressed, such as temporary transfixation through the distal radio-ulnar joint, a radio-ulnar fusion, or an ulnar shortening osteotomy. So transfixation of the DRUJ by itself is insufficient, and there is always persistent instability, and there is a missing radial buttress. So when there is a delayed diagnosis, which is by far the rule rather than the exception, there is a dorsal subluxation of the ulna with an ulnar advancement and pain in the distal radio-ulnar joint. And then this is again a very characteristic feature that you'll see on table, that the ulna really is kind of very unstable. And as you can see from the fluoroscopic picture also, you can appreciate how unstable the ulna will be. So the treatment essentially depends on the status of the TFCC, which can either be diagnosed with an MRI or a wrist arthroscopy. And the treatment options are myriad. You can either choose between an ulnar shortening osteotomy, a cervic appointed procedure, a prosthesis for the radial head or the DRUJ. And the Deras procedure, you can do a callus distraction, or the last salvage procedure is that of a one-bone forearm. So radial shortening osteotomy perhaps by far is the most frequently performed procedure and is favored by a lot of authors. It's usually indicated in younger patients with high functional demand, and if the instability is unidirectional, and if the TFCC is intact. So all of these are prerequisites in choosing or opting for an ulnar shortening osteotomy. And you may either perform a straight or an oblique osteotomy. You may want to use a jig, or you can do a freehand technique. And what is essential is that you need a perfect reduction, and you should not take off more than 4 millimeters of the ulna. So case in point, here is an SX Lopresti kind of a variant. The radial head was resected, unfortunately leading to an ulnar positive because of proximal migration of the radius and a significant instability in the distal radio-ulnar joint, and an ulnar shortening osteotomy with temporary transfixation of the DRUJ has been done. I prefer not to do this now. I prefer to use a tenodesis procedure, an additional tenodesis ligament reconstruction procedure, rather than using KY. This is kind of early in my practice. So Sovic apondyle is indicated in the young active patient with significant dorsal subluxation and a damaged TFCC. I'm sorry that I forgot that there's a typo out there. And then this is basically to prevent further migration of the ulna and to give good grip strength. But the problem with Sovic apondyle is that it causes an instability of the proximal ulnar stump, and there may be reactive bone formation, across the pseudoarthrosis that you have created, and then you are now converting an ulnar impingement or an ulnocarpal impingement into a convergence syndrome, or the radio-ulnar impingement syndrome for that matter. So Sovic apondyle is again one of the options that has been described. And as you can see that there is this dorsal subluxation and instability of the proximal stump of the ulna. Now, there have been procedures that have been described to stabilize the proximal ulna, but I'm not sure if they are really good methods by which you can prevent it. Prosthesis for the radial head again is indicated in fresh fractures. It basically acts as a spacer, but we should not use the silastic implants. The biomechanics have now become more reliable, and the caveat is intra-articular overstuffing, or even for that matter, understuffing. So again, case in point, the radial head prosthesis is something that is an option when you want to consider treating these in the acute stage. Deras procedure is resection of the ulnar head. It is usually indicated in elderly patients with little demands or low demands. Again, something which is not really favored, but there may be some indications where you can do a Deras procedure. Callus distraction was described by Capuano, and this was published in the Journal of Plastic and Hands, the Scandinavian Journal. We have very little information in just one case report, so I just included this for the sake of completion or as an option that may be present. And of course, the salvage procedure, which is a one-bone forearm, wherein this is an end-stage procedure, usually indicated in elderly low-demand patients or even in young patients where nothing else is possible. So the take-home message again is that this is a rare injury, but you need to keep it in mind so that you don't miss the diagnosis, and think of it if more than 2 millimeters of ulnar lengthening is present and the DRUJ is painful. In acute injury, reconstruction of the radial head should be our first endeavor. And if not possible, you may want to resort to prosthetic replacement and a metallic prosthesis, not a silastic prosthesis. And then you evaluate the DRUJ and then decide to stabilize it if required. Again, referring to the Edwards Jupiter classification, type 1 is when you have Mason, type 1 or type 2, you would perform an open reduction internal fixation of the radius and then assess the DRUJ's instability. Type 2 is when there is a Mason 3 or 4, and then you would resect and you would replace. In type 3, chronic case with proximal migration of the radius, you would do an ulnar shortening, osteotomy, and a prosthetic replacement of the radial head. So what about those conditions or those cases who present late, and that's more often the case? Your options are shortening, osteotomy, or cervicopuncture. They're more or less salvage procedures to address the distal radio-ulnar joint, while no attempt is made to reconstruct the interosseous membrane of the forearm. So with that, I thank you for your attention, and I hope that I've been able to do justice to this, ill-addressed topic in orthopedic literature and orthopedic webinars. Any questions that anyone may have, I'll be happy to answer them. Thank you very much once again.
I would want to ask you, why did that case come back to you after 7 years? What was the problem?
He was having pain along the ulnar forearm, and although it was not very severe, it was enough to draw his attention, and his inability to perform certain activities like lifting weights. He is a fitness enthusiast and he's unable to go to the gym. But I haven't been too keen in pushing him for surgery. I've asked him to, kind of evaluate it objectively. If he can live with it with activity modification, so be it. And if at all he's really keen on pursuing it, he may want to come back, and then we can explore some options for him.
So you mean to say he didn't have the problem earlier, and over the years, this problem has become worse?
About 4 months, for the past 4 months now. For the past 4 months.
Why would that happen?
I have no clue, ma'am. I think it is because of the DROJ instability. A lot of times, it's his non-dominant hand, and then he may not have realized or recognized this earlier on, and then now that it is at a threshold, or rather beyond his tolerance threshold, I think that's why he's come to me for some solution. But I'm not a trigger-happy person. I have counseled him in a manner where he can explore using a brace, avoiding strenuous activities, lifting weights, modification of activities, and I want him to kind of ask for the surgery rather than me selling him the surgery.
What is the incidence in your practice to get these type of cases?
So most of them, I don't get them as a fresh injury. Most of them are delayed presentation. So far, I must have seen about 7 or 8 patients in the last 20 years or so, and operated only about 3 or 4 of them. So most of them, they might not turn up for surgery, and they are not very keen on getting the surgery done. I'm not sure if you were there for the wrist course in Pune. There was that lady with an Essex locusty that we had discussed, and she never turned up for surgery again. So I think they are not very demanding, or they learn to perhaps accept and live with whatever pain they have. And I think the ones that turn up, and as I told you, I am not trigger happy. For these patients, you have to really temper your enthusiasm for a surgical intervention, because whatever you do, you're only trying to deal with one aspect of the entire spectrum of the injury. So say, for example, you're doing an ulnar shortening osteotomy, you're trying to stabilize a DRUJ, whereas the problem in the proximal radio-ulnar joint still remains, or the interosseous membrane still remains. So they'll always be unhappy campers, and I really wouldn't push. I wouldn't push the envelope for surgery unless and until the patient is really, convinced and understands the outcomes, understands that there may be limitations of the procedure, and his problem may not completely be addressed.
Yeah, Dr. Vinit, you want to ask?
Dr. Abhijeet, can I ask you something?
Easy question, only an easy question, not difficult question, please.
Okay, it's an easy question. Instead of clinical diagnosis, what other modalities would you use to get this interosseous membrane? Either it is intact or a torn one or anything. Any MRI or ultrasound or
Yeah. So when I was training in France with Professor Christophe Oberlin, he had also developed a ligament reconstruction procedure. And at that time, they did a cadaver study where they kind of incised the interosseous membrane and tried to look at the sensitivity of ultrasound in diagnosing those tests. So ultrasound, we all know that over a period of time, there is bound to be fibrosis, there is bound to be some kind of an attempt at healing. And the tests may not be readily evident on even MRIs or ultrasounds. But the ultrasound has the ability to, you can do it as a dynamic examination. And a good sonologist may be able to pick up the tear. However, more than that, if the patient does come in for surgery, the radial longitudinal instability test that I described, wherein if you apply towel clips and you pull on the radius, and if the displacement is more than 6 millimeters, that is almost 100% sensitive and specific for an interosseous membrane tear. Now, again, having deliberated all of these points, we all need to understand that interosseous membrane, whether it is torn or not, our attempts at reconstructing it are really very feeble and they are not very reliable. So ultimately, the focus of the treatment remains on the radial head and the distal radio-ulnar joint. So from that perspective, we should deal with this in as efficient a manner as possible.
One question from Dr. Ashok Khandaka, Jaipur.
Yes, sir.
He is in audience.
Also,
he asked that if suppose the same patient comes back to you and demands for surgery, what will you offer?
Yeah. Good evening, Khandaka sir. Good to hear from you. Thank you for the question. We all, I think, as orthopedic surgeons know that the best treatment is something that is time tested and what works best in your hands. And I think we need again to take into consideration that whatever we do for our patients, what we choose for our patients is something that should work for him in the long term. And we should try and minimize the necessity for, repeat surgeries or whatever. And having said that, ulnar shortening osteotomy is something that is time tested, has stood the test of time. And if you adhere to the principles of ulnar shortening osteotomy, namely, one is that you should not resect more than 4 millimeters of the ulnar. Your osteotomy should be well planned, and the reduction and the apposition of the osteotomy should be as accurate as possible, using good implants and performing a good procedure, and then placing the plate on the volar aspect of the forearm underneath the flexor carpi ulnaris. All of these will give you reproducible and reliable outcomes. So if you were to ask me one procedure, I would say ulnar shortening osteotomy. Again, one caveat is that the instability should be unidirectional with the TFCC intact. However, you may also deal with a multi-directional instability performing an ulnar shortening osteotomy and then combining it with a distal procedure such as a Breen-Jupiter procedure, modified Nakamura procedure, or maybe even the Bryan-Adams procedure, wherein you use a tendon graft to stabilize the DRUJ instability in the volar direction. And I really wanted to present that case today where we had a Galeazzi fracture dislocation, which was treated elsewhere, presented with a multi-directional instability of the DRUJ. We did an ulnar shortening osteotomy. and then it just corrected the instability in the volar direction, but the instability in the dorsal direction was still present. So we did a modified Nakamura procedure, and that addressed the instability of the DRUJ. I hope that answers the question.
Yes, because in routine trauma surgeon, they are getting forearm bone fractures. So I would like to suggest suggestion by you that how they should restore the as much as normal anatomy of radius and ulna. What are the tricks for that?
I'm sorry, I'm very sorry. I just had an emergency patient call. Can you just repeat the last part of the question, please?
So, because forearm bone fractures are having a lot of incidence in general orthopedic practice. So, what will be your suggestion to restore the normal anatomy of radius and ulna? So,
yeah. First and foremost is that whenever you're facing Galeazzi or Monteggia kind of fracture dislocation, please do not fall into the temptation of using a nail. It is really a disservice that you're doing to your patient. So please use a plate and a rigid fixation. And I think restoring the anatomy itself addresses the instability part of that injury. Now, when there are both bone forearm fractures, again, I think we are moving away from using nails, and especially if there is comminution, there is no way that we could restore the anatomy by using a close reduction and nails. We really need to open up, reduce properly, address the comminution. If the fragments are small and if they still have a soft tissue attachment and they can just be used as onlay grafts, you can bridge the fracture, fix it rigidly, and use those comminuted parts and just leave them there and hope that it heals. Otherwise, if for whatever reason, the better judgment in your mind tells you that you should use a bone graft, it's better to overtreat than to undertreat. I would not hesitate to use bone grafts. And in my books, there is no better bone graft than iliac crest. So I would resort to iliac crest bone grafting. As far as the ulna is concerned, the length, as far as the radius is concerned, the bow are very important, especially for mid-shaft. You should understand the deforming forces on the radius and ulna, especially on the radius for that matter. So fractures in the distal third are having a different kind of reduction technique because of the muscle forces. The middle third will have different, and the proximal third will have different. Your approach has to be very important, and it has to be well planned and executed. So you cannot, get a good approach, and you will not be comfortable for a proximal radius via a volar approach because there is just so much of soft tissue and vital structures out there. So depending upon the location of the fracture, please choose your approach wisely. Please choose your implants wisely. Please understand the fracture mechanism and the anatomy, and then accordingly deal with. So I think these are just basics that we all studied and all have been through, and we just need to revise and revisit those basics to deal with these fractures appropriately. Ma'am, I'm sorry, I'm far way junior than most of you are here. I hope छोटे मुंह बड़ी बात नहीं की. आप ही लोग बताएं, मार्गदर्शन करें. मैम आप म्यूट पे हैं मैडम.
अनम्यूट कीजिए. अनम्यूट कीजिए.
Can you get a proximal instability of more than 4 millimeters or 6 millimeters with an intact TFCC?
If the intraosseous membrane is torn, yes.
You can.
Yes, you can. Up to 6 millimeters. In fact, if it is 6 millimeters, it is a definitive indication for an intraosseous membrane tear. So, if you revisit Mark Garcia Elias's talk on DRUJ, the concept of DRUJ, it's a beautiful way he has described the different soft tissue restraints and how they act. So the forces that are mitigated, in pronation, mid-prone, and supination, and the parts of the TFCC are very important. So the TFCC basically acts locally in rotational movements rather than allowing for longitudinal stability. The longitudinal stability is imparted by the intraosseous membrane. And if there is a through and through tear or a complete tear of the intraosseous membrane, and of course there is a proximal radial head fracture, then you would have an instability which is quite significant.
Have you ever encountered, say, an anterior intraosseous nerve palsy with a fracture like this?
A radial head fracture, yes, madam, but not with an Essex loop ST. No, I haven't. With a tear of the intraosseous membrane, I haven't seen one. I haven't seen one.
Two questions from audience. One again from Dr. Khandaka sir. He's enlightened after your talk, and he told that if suppose you have underwent the prosthesis for the patient and he presented with same symptoms, what you will opt?
So again, Khandaka sir, thank you for the question and thank you for the comment. In India, unfortunately, we don't have very good options for revising a radial head prosthesis, and especially if previously a cemented radial head prosthesis has been done, it really becomes a big problem to deal with these injuries. And I will play the devil's advocate and say that perhaps the best solution for these patients is either to live with the problem or to offer them a single bone forearm surgery. Because the more you resect the radial head in a revision surgery, or if you have to, for whatever reason, the previously done processes, the resection has been quite significant. We don't have those stem lengths, or we don't have those prostheses which mimic the normal biomechanics and the anatomy of the proximal radial joint yet. When you're doing radial head prosthesis, there are 2 points that are important. One is that the head has to match the sigmoid notch, the proximal sigmoid notch of the ulna, and also has to address it has to match the capitulum. So revision surgery, the valgus angulation of the proximal radius is very difficult to restore it, and also to match the height, because we simply don't have those processes yet. Hopefully in the future, as the world is becoming flatter and more industries are coming into the picture, we might have the options. But I'll leave you with one more piece of information. I'm sure you all must be familiar with the Shecker prosthesis for the distal radio-ulnar joint. Recently, when I met Professor Louis Shecker in Berlin in 2019 at the International Federation meeting, I was very pleasantly surprised to learn that he's also devised a similar prosthesis for the proximal radio-ulnar joint. So these hopeless cases, maybe that might be an answer. But just to kind of summarize and put it in one sentence, it's a difficult situation to salvage.
Okay. One question, Dr. Prakash Mal, that sir, how to calculate exactly 6 mm translation on image intensifier? First. Second thing, is there any chance of overstuffing the lunate bone following ulnar shortening osteotomy, and how to avoid it?
So I'll answer the first question. So the measurement is at the distal radio-ulnar joint in relation to the head of the ulna. So the same image factors or magnification, so you're not going to change it, right? So when you take an image, so we like to take what is called as a neutral view of the wrist joint, which is with the shoulder in 90 degrees abduction and the elbow in 90 degrees of flexion. And a PA incidence is taken, and without the traction being applied. And You would look at the image and store it, wherein you would note the level of the head of the ulna, or the stylet process for that matter. And when you apply the longitudinal traction proximally, you would take another image, and then you would measure the difference between the two positions of the head of the ulna, or whatever your reference point is. But obviously your reference point is at the distal radio-ulnar joint in relation to the ulna. So I hope that answers the question. The second question was?
Is there any chance of overstuffing the lunate bone following ulnar shortening osteotomy, and how to avoid it?
Overstuffing the lunate? No, in fact, by ulnar shortening osteotomy, you are addressing the ulnocarpal abutment. So not overstuffing. You are changing the or you are addressing the ulna positive and shortening the ulna, and thereby you are addressing the ulnocarpal impingement. So it's just the other way around, in fact.
Okay. So another question from audience: inform the radiology tips point not to miss these injuries.
So good question, in fact, and I never tire myself of talking about this, especially to our residents and for fellows also. Whenever you have any forearm injury, we've all been taught this by our teachers. Always image the proximal and the distal joint. Okay, forearm fractures, you should look at the elbow as well as the wrist. Now, if there is a radial head fracture, always look at the distal radio-ulnar joint at the same time. And then clinically also, you examine the patient. Obviously, in the acute setting, the patient may be in pain, but you can always call the patient back for a repeat examination and entertain this diagnosis. So if there is a comminuted radial head fracture, suspect SX lopresti and rule it out. If there is a forearm fracture or kind of a Galeazzi variant, always look at the DRUJ. If there is Monteggia, look at the PRUJ. And Galeazzi, although rare, may be a possibility. And this is something that you may want to consider as a possibility in comminuted fractures of the radial head. So vice versa is not often applicable. So if you have a DRUJ injury, these patients will usually not have a radial head fracture.
Okay. And another question from Dr. Ashok Khandaka. He wants to know the experience of Purnima Patni madam and other faculties about dealing with symptomatic case after radial head excision. Unmute, madam, please unmute.
I haven't done it in ages. Radial head excision. So I can't really say.
Anyone wants to comment on this?
The question is after symptomatic radial head malunion.
No.
Excision.
After radial head excision, have you any experience how to deal the symptomatic cases after radial head excision?
Okay. Well, this is exactly the gist of this talk. I mean, so the symptoms will, are you talking about symptoms in the proximal radio-ulnar joint or symptoms in the distal radio-ulnar joint? If it's in the distal radio-ulnar joint because of proximal migration of the radius, you would then think of doing an ulnar shortening osteotomy. But for the proximal radio-ulnar joint, it is a difficult situation in the late presentation. Radial head replacement may not be the best way to deal with it, but that is an option. That is an option.
When we were students, it was a standard treatment for any comminuted radial head fracture to just do an excision of the radial head. And then we would transfix the distal radio-ulnar joint for a period of 3 to 6 weeks with just K wires. That is what we used to do. But subsequently, we have not been excising radial heads.
Okay, if no other question, then shall we move to our case presentation part? So, are you able to see screen? Yes. So this 20-year-old right-hand dominant engineer, he used to inspect his solar systems. So he was inspecting his solar system at a height of about 60 feet, and then he fell down. Probably he fell down at a height of 40 feet, and he had pain and swelling and lacerated wound in the forearm. He had multiple laceration in head, and pain and swelling in dorsum of the hand also, and he had lower third tibia fracture. So just for just subject, we will discuss the forearm fracture here. So these were the X-ray pictures. Rahul Garg sir, can you read for me the X-rays? Sir, please unmute yourself. Please unmute yourself.
These are the X-rays, right forearm with segmental fractures of both radius and ulna, probably with combination. Ulna is the plaster view. So it is a radius, it is a segmental fracture, and ulna it is a severely comminuted fracture with a large butterfly with radial head dislocation.
With radial head dislocation.
Yeah. What is the neurovascular status and upper limb?
That is okay, but he is having diffuse swelling of the forearm. Dr. Rajeev Gupta sir, you want to add something?
There is some disruption at the distal radio-ulnar joint also, seems to be, and and it is a compound. Looking at the combination on the ulnar side, it is going to be open wound.
Open wound. Small lacerated wounds are there. Yeah. Anything about elbow dislocation?
It is there. It is already mentioned by Dr. Rahul Gar. It's a disruption at the proximal radio-ulnar, and lateral view is not clear, too difficult to comment, but it is there. Elbow is dislocated there.
So elbow is also dislocated, and it was reduced. And this is a X-ray of the hand. He had fifth metacarpal neck and base fracture, and so he presented after 24 hours. You can see the elbow dislocation here in the X-ray.
Yeah.
W sir, you want to comment on this? Anything? Wahegaonkar sir?
Sir, just 1 minute.
Yeah. Amit, Mittal?
Very sorry, sir. I had this pediatric crush hand injury. I was just talking to the emergency room. Can you please repeat the question, or maybe Amit Mittal sir can take it? Sir जी आप कहिएगा.
I think all have been explained by Rahul sir and Rajeev Gupta ji, that it's a complicated fracture of radius, ulna, dislocation of the radial head, and lacerated wound. I think now Abhijeet Wahegaonkar sir only could tell the management which one to fix.
Wahegaonkar.
Well played, Mittal ji. I think again, so you know, there'll be a lot of temptation. Is this a compound injury or is it a closed injury?
Yeah, it is compound injury, and he has lacerated wound on the ulnar side of forearm.
Okay, so it's kind of a grade 1 or grade 2 kind of a injury, puncture kind of, because of the fracture, not a, so it's an inside out injury, not
Yes.
an outside in.
Yes, yes.
What about his compartment?
He has diffuse swelling in the forearm.
Okay, so I would begin by addressing the length. So my first endeavor would be to fix the ulna. Even if it is a grade 1, grade 2 compound, we all know very well that it can still be fixed with internal fixation and plating. So obviously, looking at the fracture, you need a very long plate. I would make every attempt to get at least 3 or 4 screws or 6 or 8 cortices on either side of the fracture. The radius fracture can either be addressed by, so it's a segmental fracture, does not appear comminuted, and the dislocation is kind of a pseudo kind of a thing. Once you restore the ulnar length and you restore the bow of the ulna, of the radius, I think it should be okay. Now, radius could either be 2 different plates or 1 single plate, or yeah, I would want to plate it rather than anything else. I'm sure there may be people who would want to introduce a closed nail, a hybrid kind of a fixation perhaps, where you plate the ulna and nail the radius. I think whatever is available at the place where you're working and your philosophy would dictate how you would deal with this.
Okay. Anyone wants to comment on at this stage?
Yeah.
Want to add something?
May I interrupt?
Yeah.
When Amit Vyas asked me question just to detail this X-ray, and I was thinking what to fix first, which bone to fix first. So what I thought, just Abhijeet sir can comment me and correct me where I am wrong in telling, because the fracture of the ulna seems to be comminuted, and in the radial side, fracture is a segmental but not a combination, but radial head is dislocated. So I thought first to plate the radial, the segmental part, both sides, so that I can know when I will deal with the ulna comminuted fracture, then the radial head will get reduced or not. This is my thought process when I was thinking to why to fix radial first. So when I manipulate to the comminuted part of the ulna to maintain the length, so the radial at what length or the distraction of the ulna, the radial head get distracted, I may take that point to fix the ulna. This is my thought process. Abhijeet sir, kindly correct me.
No, I think you're right, but that's exactly the point. Once you restore the ulnar length and the angulation, the proximal radial ulnar joint will automatically take care of itself. One, and obviously when I say that I'll fix the ulnar first, it means that you have exposed both the radius and the ulnar simultaneously. And it's also important to get a traction view also, when there is such combination. So on table, before you commit yourself to an incision or before you open up, get a traction view. That also kind of makes these scary looking x-rays seem much more tame than they usually appear on such x-rays. And I would still go with the ulna first, because that's comminuted. It's all the more reason why you have to be very particular in restoring the length and the angulation, correct the angulation of the ulna. Once you do that, it just becomes easier to restore the radial bone.
Sir, can I ask you, Dr. What would you take the reference point of ulna, that this should be the correct length of the ulna?
The opposite side X-ray, sir.
Okay. But clinically, while operating.
So we have been taught this by our respected Sancheti sir that we all know this templating, you know. So in such way, we don't do. I mean, you need not do it necessarily in all injuries, but when there is a challenge, when you need to know, for example, even for the scaphoid, just we are moving away from the topic, but sometimes when there is a severe angulation and a non-union of the scaphoid, you would want to know this length of the opposite scaphoid just as a reference point. And if you just reverse the image on your computer, you would know the length of the ulna as well, and that would be your reference point. Especially in these difficult fractures, when there is a comminution, when there is a segmental fracture of the radius, when there is a little bit of a doubt as to how are you going to overcorrect it or undercorrect it. So always get an X-ray of the opposite forearm from the elbow to the wrist and template it so that you know the length. Now, you remember, I'm sure, when you were doing your residencies, when you used to use a nail, wouldn't we measure it on the opposite side, right? And you would need an X-ray of the opposite side to know the diameter as well as the length of the nail that you would use. So you're better prepared. So likewise, even for a plate, I think it would be very helpful to get an X-ray of the opposite side and then use that as a template or a reference point.
So, Katta sir, please.
Dr. Abhijeet, I have two questions for you.
Yes, sir.
First one is, would you like to graft ulna primarily in this case or not?
I will not hesitate to if I would. So all of these cases in our practice, we prepare the iliac crest, we consent for use of a bone graft. So if on table we feel that the comminution is something which is difficult or is getting in the way of restoring the length, I will not hesitate to graft. So
just for restoring the length or for the union, because strong they are. So there is no need for primary grafting. This is the current concept.
Yeah.
But in this case, another one is, if you are using a single plate for the radius, would you bend it or contour it to restore the radial bow, or would you like to use two different plates?
It is best to use two different plates because one single plate, the dissection itself going under all those muscles, the flexible. So in fact, for the proximal part, you could go use a Thompson approach. And for the distal part, you can use a Wöhler approach, the Henry's approach, and get two good plates and, convert the segmental into, if you say, for example, fix the proximal first, converting into a single fracture then, and then it just becomes easier. And if you look at the X-ray carefully, they are very good, these hatches in the radius that you can use to your advantage to control your rotation and match the edges to get the correct. It's not really very comminuted, although sometimes you may be surprised to find some comminution when you open up. But I think it would be quite manageable. The radius I'm not too concerned about. The ulna, yes, I am.
When you are using two different plates with the two different approaches for the proximal and the distal one, so whether you use both the plates in the same plane or in two different planes?
I would
different plane, you have to strip the periosteum. I mean, the vascularity of the middle fragment will hamper.
True. So obviously you should not really denude the fragment and strip it of its periosteum. The LC-DCP plates that are available help you, to place the plate without having to really strip the periosteum. So you can just, dissect around the fracture end so that you're able to match the fracture ends properly, align the fracture fragments. And then, or else you can even use a temporary intramedullary nail to facilitate your reduction and then use a plate. So there are many ways that you can skin the cat. It all depends upon, the availability, your philosophy. But I would not perhaps put both plates in the same plane simply because getting 3 cortices on both aspects of the intermediate fragment will be quite difficult, and it's too tempting to use on one side only two kind of screws and on the other side 3 screws. I'm not very comfortable doing that. Rigid fixation is of paramount importance.
Dr. Abhijeet, 2 questions for you, please.
One last question to all the faculty members, the younger faculties. The fancy MIPO technique, anyone like to use MIPO technique in fixation of the radius in this case? Anyone thinking for that even?
Too dangerous.
Not in such injury.
Never used that. Dr. Abhijeet,
sorry.
Yes, please continue.
My submission is that once you have managed to restore the length of the ulna, the radius will more or less fall into position on its own. And very simply, without disturbing the periosteal sleeve or anything, you can slide in an intramedullary nail. And why are we so hell-bent on rigid fixation at the cost of vascularity of the fragment? So I would really plate the ulna and do an intramedullary for the radius.
One question from audience. Because of combination, judging the length of the ulna is difficult. So what is your opinion about this?
That's exactly what we talked about. You would use the opposite side as a template, or you would measure the length of the ulna with the opposite side, get an X-ray of the opposite side with same parameters of the X-ray that you're taken on this side, and then that give you an idea about the length. And Madam rightly said, I'm never ever shy of using, like I said, in these fragments, these kind of cases, and I did submit that. I said you would want to restore the length of the ulna with a plate and then maybe use an intramedullary nail for the radius.
Dr. Yeah.
Yes. I want to ask how to make the radial arch that is present on anteroposterior view. You see the radial bowing is there. So how would you like to manage that? With the plate, the radius would be a straight on the forearm, and
yeah, so that's why
fixation.
So intramedullary fixation, sometimes you may have to make a small incision to manipulate or to navigate the nail, and then the shape of the nail itself would restore the bow of the radius. Now, like you rightly said, a single plate will make it very difficult for you to restore the bow, and that's the reason why 2 plates.
One of audience has asked about that. If you will use 2 plates for ulna and radius both, then are you expecting any wound closure problem?
So usually these fractures are not an emergency. You would wait for the soft tissue edema to settle a little bit, maybe 2 or 3 days down the line you can plan it. If you do not close your fascia, usually not a problem. Put in a drain and stick to the surgical time. You should not, the surgery should not be too long drawn out, because that's usually the reason why once you let the tourniquet down, a lot of swelling, and that leads to edema and closure problems. Sometimes, yes, we do encounter these issues, but I would, one more caveat of just kind of to play the devil's advocate, never ever hesitate to refer these cases to someone who's more experienced, or bring in a colleague to help you out when you're doing these fractures. Collaboration is the key to success. And I think that's something we need to really think about when we're dealing with difficult fractures. So please talk to your colleagues, your senior colleagues especially, take them into confidence, and do it at a center that is equipped with all sorts of armamentarium and infrastructure. And always do not hesitate to collaborate with a colleague who would help you out with these fractures.
Dr. Abhijeet.
Sir, please. Yeah.
Dr. Abhijeet, can I ask you
Yes.
one question? This is Dr.
Yes,
Arun.
sir. Yes, sir.
So
Yes,
looking
sir.
to the pattern of fracture, comminuted, swelling, and such a gross injury, do you have any experience about the external fixation? Because plating would definitely give you a problem, double plating on radius and then plating on the ulnar side. So
Absolutely.
what do you say about the external fixator?
Absolutely, sir. It may be an, but I wouldn't use it as a definitive treatment, to be very honest. So, more often than not, we have seen problems with the external fixator than otherwise. It is an option, no doubt about it. So again, so when we are working in institutions and sitting in our offices and having good infrastructure. I am completely aware of the fact that I am talking about the ideal way of dealing with this and the way it is dealt with in tertiary level centers. But the same patient may be, at a center where all these, infrastructure and armamentarium may not be available. The patient's socioeconomic status may not permit. But when we are talking in a webinar or in a conference, obviously we do talk about what the ideal or the most effective and efficient way of treating this fracture would be. But circumstances might dictate that you may have to use alternative methods of fixation. And as long as you are facilitating or addressing biology and mechanics, and if it were to unite, so be it. Absolutely. I mean, these have been modalities that have been used by so many of my teachers, so many of my colleagues, and it is a viable option. But the healing may take longer. There is a loosening of the fixator at times, so on and so forth. But again, there are problems even with plates. Likewise, there may be problems with fixators also. So choosing the lesser evil, let me put it that way. But point very well taken, sir. And I think that is an option that can be considered.
Thank you.
Thank you, sir.
So I will ask to Dr. Narender Saini and Yogesh Sharma. Are you in favor of fixing radius first or ulna first? Dr. Narender Saini. Okay. Okay, so probably he's not here. So one question.
Sometimes silence is golden.
And one question from audience. Should we evaluate the elbow for stability at this point?
Anyone wants to take that question? No, I mean, the elbow stability is not an issue in such injuries.
Okay, so up to this time, the conclusion is that fix the ulna first with either probably with the plate, maintain the height of the ulna, and then you can choose the radius, fixation for the radius. It may depends upon your condition. Sir, Arun sir, please.
No, nothing. No.
Okay. Okay. So because he presented to me in the night, and at that time there was diffuse swelling. So my thought process was in the same line, and I tried to restore debrided the ulnar wound, restored the ulnar length, and fixed with the plate. And then because of swelling, I thought why not do the procedure for the radius in a later stage, because it has given me the some stability, and I can maintain in the plaster, and I can deal later on. And up to that time, I will be clear that what will be the condition of the wound. So, any critical comment?
The elbow is not reduced.
Yeah, elbow is not reduced.
What were the status of this comminuted fragment? It is with the periosteum, or it is totally stripped off? That you kept it.
Two pieces were stripped off.
You kept it only like that.
Yeah.
So you find good stable fixation of the ulna with this graft. Then it's fine.
W, sir.
I want to know what you did next.
Okay. So somehow the swelling took time to settle, and I was able to do neck surgery after 15 days only. And that time, because the ulnar fragment, as Amit told, that he assumed that they were devoid of periosteum. So at that time, I removed those one and used the fixation was done again, and used iliac crest bone grafting for the ulna, and segmental radius was fixed with single plate, and somehow I was not able to reduce elbow joint after that. So I reduced it and fixed with one wire, and still radial head was outside. So what went wrong? What was the wrong step I took?
Firstly, you can't leave a dislocated elbow for 2 weeks. You should not. That should have been addressed more urgently.
Well, the dislocation is an emergency, not a fracture.
Yeah.
Okay. Any comment on this fixation?
Full length.
Full length X-rays.
Yes.
The elbow is still reduced? I hope it is still not reduced.
Elbow is reduced, but radial head is dislocated.
I think there is shortening of the ulna.
Shortening of the ulna.
Or you can say the radial bow is not there, so there is a little bit lengthening of the radius. Because you have straightened the radius, so its length has increased a little bit.
Yes.
So that is creating some issue.
And the rotation. Rotational malalignment causes external rotation at the head of the radius. That also causes it to come.
So the same thing because I faced this problem. So any tips to restore the bow of the radius?
To discuss double plating.
Double plating in different planes.
Yeah, or a flexible nail, intramedullary nail.
Or plate on the radial border and curve it accordingly. Or apply a curved nail, that flexible nail that will match the curvature of the radius, because you are going to place the both of the edges, so the curvature will be met.
So even a 1/3 tubular plate is a little soft and flexible. It sometimes gets away with compensating for the curve of the radius. It's not very rigid, but you know that difficulty of a rigid plate is not there.
Small DCP is also a little bit flexible than the LC DCPs. So it is easy to bend those plates. It's simple.
You can have a rigid plate for the ulna and have a 1/3 tubular plate for the radius.
Yes, yes, definitely.
Abhijeet, any comments?
One question from audience. Is the first fixation of radius would have saved this problem? Anyone wants to comment on this?
That depends on how you restore the mechanics of
Length of the forearm.
both the bones.
That depends, Amit. When you fix the ulna and then when you plated temporarily, you fix the radius. That time you check the radius, radial head, or after completely fixation you check the radial head. What is the thing which make you alert that it is not during the temporary fixation of the radial has not reduced? Did you mind if you revise the ulna fixation? Maybe it is not lengthened properly. That is one reason because of combination. I'm just asking, what is that you thought during the surgery? It is delayed after 2 weeks. Some soft tissue is there, which is blocking the reduction, or the fixation, ulna fixation is not distract. The true length of the ulna may be one, as Abhijeet sir has rightly pointed that ulnar length is one major issue that prevents the reduction.
Yes, agree with the point that after exhausting too much and fixation, somehow I was able to reduce the elbow joint. Then I thought I will deal with the radial head later on.
You know
Because
that if the length of the ulna is not a true length, and you will, if suppose try to reduce the radial head, then the distal radio-ulnar joint should get ulna positive negative variance length. So did you find something like that after reducing the radial head? The pronation supination got restricted because of radial lengthening after reducing the radial head. If suppose the ulna is short and you reduce the radial head, then distal radio-ulnar joint should get unstable.
Agree with the point.
Abhijeet sir will take out. That's why he's silent.
Yes, I'm discussing because as in the initial part it was missed, and it is a difficult problem. So we'll not repeat the same mistake again.
Anyone want to comment on the length of the plate of ulna? So I would like at least one or more, two more proximal screws in the ulna. So plate length should be more.
2 more screws.
1 or 2 at least, because it is a comminuted fragment. We want a rigid fixation of the ulna. So you have fixed 5 cortexes. I'd like to fix at least 8 cortexes.
8 cortex.
Then that is my opinion. If anybody wants to comment on this.
I think overall, because distally I have already used 4 screw, and the third one is engaging 1 cortex. So anyone wants to comment on this? Okay, we'll take this question later on. What is expectation at this time? Because radial head is unreduced, and what problem we may face later on. Patni madam, could you take this question? And what should be done for rectification at this stage? Suppose we realize this in immediate post-op. So sorry.
Very difficult to answer.
Anyone wants to take this question? Wahegaonkar sir?
I think at this stage, you should wait until the bone has healed. Now you've done what has been done. then assess the function and based on that take a decision. I don't think I would intervene, or we should intervene at this stage and do anything. So, what was the? But I would also be a little concerned about cross union between the radius and the ulna. You should warn the patient about it. So, can you please share the outcomes?
Okay, you are having suspicion about cross union. Can this unreduced radial head can be problematic?
I don't know. You should tell us what happened.
No. I'm asking
Once you remove the
can it may
and
produce some radiocapital arthritis and all?
Yeah, a lot of things, in fact, might occur. But I'm sure you will show us an amazing outcome.
That's what he's working on.
Retrospectively, one question from audience: can radius nail would have achieved the good outcomes in comparison to plate?
Long time ago, I had read a phrase. It is not the sword, but the hand that wields the sword that is important. So it is not the nail or the plate. Anything that is done well and following the principles should work. So yes, there is every possibility, and we discussed this already, that the nail could have also been as efficient.
So the point is clear. I think the ulnar length should have reduced properly, and if I would have done double plating for the radius to improve the curve, the elbow problem would have sorted out. So this point is taken.
No. That's not the point. In fact, the ulna itself, is one of the most important criteria for the elbow to be the radius to reduce also. Of course, in this fracture, there is an element of a segmental fracture. So both are equally important. So restoring the ulnar length and avoiding an angulation, as well as restoring the radial bone.
Okay.
Amit, we are far ahead of time.
Okay. So these are the part of ulna I removed, and we discussed all these things. This is full length X-ray, and by the grace of God, ulna united well, and also radius. And at 1 year follow-up, this is the condition. Patient is having this much range of movement at elbow, but his supination is restricted. Terminal supination and terminal pronation is restricted. And I explained him about the radial head, but up to now, because now it is 1.5 years, something in X-ray I can see. Can anyone is with me that some problem, some in the radiocapitular joint is developing arthritis, or at this point, how we should proceed? Still, the condition is same.
Wait for arthritis.
Sorry?
If no problem, leave him.
Okay.
If the patient has got no complaint, then why to interfere?
Yes. Because he's an educated patient, he always asks me that is any in future there will be problem with this dislocated radial head.
No. Has he got any complaint right now?
No, he is not having any complaint.
So it's better, nothing to be done.
Yes.
Leave him very well good, he'll do good.
Okay. So that's how we learn from our mistake. So I will say next case. So this 32-year-old male, he's right hand dominant. He's property dealer by occupation. He had forearm bone fracture of left side, which was fixed with nail 3 years ago. Now he presented with inability to extend his thumb and supination of forearm is restricted. So this is range of movement at wrist. And he is having good pronation but no supination. Hand is stuck in mid prone. And he had some scar mark at the entry of the nail site, and he is unable to extend his thumb at IP joint and also some drop at the MP joint. And his distal radio-ulnar joint is dislocated, you can see, and it is dorsally shifted. You can see here, you can see the prominence of the ulna. So these are the skiagram. So Amit, Mittal or Vineet, can you take what has happened, what is finding in skiagram?
So in X-ray, we see that the radius united well, but the ulna is dislocated, and that you said EPL, that EPB is injured probably because of the entry point of that nail. Or and now the problem is that you said one is the thumb problem, that is totally separate tendon issue. But to address this DRE joint, that we is there any ulnar abutment syndrome also, or just like only supination?
No, only problem is supination. Problem of supination.
And painful supination. I think that there is no instability. So as radii is already united, there are two ways of doing it. One is either do the ulnar shortening osteotomy to bring that back, as Abhijeet sir said, or radial lengthening osteotomy. There are two things that we can do. But in this, as we know, that the primary problem is the radius. So, but it has united well. So better to do ulnar shortening osteotomy. At the same time, we can know whether this is possible to do it there or not. I think that there is no arthritis in this, in the DRE joint. And if it is the arthritis has developed, then we could have done safe Kapanji procedure.
Okay, Vineet, you want to add something?
I think yes, definitely, because there is a shortening as well as malunion of the radius is there. So unless you treat the malunion of the radius, you will not get the radio-ulnar joint back. So you have to, I think, remove this nail and do corrective osteotomy of the radius, so that your ulna, because ulna is not malunited, or ulna stays there and the wrist is fallen to the flexion part. So you have to reduce this back to reduce the head of the ulna back to the sigmoid notch, and then assess for the ligament. If it is broken, you have to reconstruct it. If it is not, then well and good. So you have to reconstruct, I think, because it is already dislocated for last 3 years. So you need not, you have to reconstruct the ligament.
Wahegaonkar sir?
Yes, sir.
Any master stroke? Why it has happened? And how you will deal it?
So again, this is a pretty straightforward kind of thing. As like I mentioned at the very beginning, Galeazzi fracture, you have to pleat it, and nailing is just not going to do anything. And this is a very common scenario. This is a very common problem we see. And now there are two. So from one single problem, which was very easy to address, you have landed up with two problems, and no, not an easy thing to treat. But in this case, I would perhaps think of rather doing a corrective osteotomy of the radius than doing an ulnar shortening osteotomy, and try to address it to the best of my ability.
Sorry, it is radial shortening osteotomy.
No, not radial shortening. There is an angulation corrective osteotomy.
And then
how much time has elapsed now since the index?
Now
surgery?
it is 3 years, sir.
3 years.
Yeah.
Goodness gracious. I don't know. I'll refer him to you.
Okay. So at this point, I want to ask for the knowledge of us that if time will affect your management, suppose he has presented immediately after the operative after 6 months, then what will be your management plan? Same.
No, I mean, see, you have to take into consideration so many different factors: the soft tissue, the sigmoid notch, the distal sigmoid notch. So it's really not easy. Maybe at this stage, you could still consider a corrective osteotomy and then deal with the distal radio-ulnar joint with something like a cervic-apongy or maybe even a shortening osteotomy. But it's not easy, to be very honest with you. But you should not deal only with the ulna and not address the radius. That's what I feel. The problem, you can still do a volar opening wedge osteotomy, put in bone graft, try to restore the length of the radius, correct the angulation, and then assess the DRU and deal with it accordingly.
Sir, just for the audience and for us,
do you have a clinical picture or a video about the DRUJ stability?
No, I don't have. But DRJ is fixed. It is not moving passively. It is dislocated dorsally.
And what are the patient's complaints?
He is not able to supinate forearm.
But his wrist flexion extension is okay.
Yeah, flexion extension, as I have shown. Yeah, this is the flexion extension. And his significant problem was about the extension of the thumb. He presented with the drop of the thumb.
That is basically from rupture of the APL.
Yeah.
So to keep it simple, I would perhaps do a cervic-apongy to restore his pronosupination, if at all, and then do an EIP to the remove the implant, remove the wire, and an EIP to EPL transfer.
Okay, sir. So in the initial stage, means I want to pull out from you that how the angulation of the radius is going to affect the DRJ dislocation, means volar angulation, dorsal angulation, and
so
can you guide?
So both bones forearm resulting in DRJ instability is a very well known and a very it's common knowledge. So when there is an angulation or a malunion of either the radius or the ulna or both, usually the radius, and more so in the pediatric age group, if there is a malunion with angulation, there is going to be DRJ instability, and we see quite a few of these patients. And the usual recommended treatment is not to go after the DRJ instability per se, but first deal with the malunion, do a corrective osteotomy. And for that, you have to know the exact apex of the deformity and then deal with it. And then once you have restored the parameters of the radius, you would then address the DRJ instability if there is any residual. But usually correcting the malunion would result in stability. But these are very different. You can see that it's a multi-directional kind of malunion and instability, and there is also a problem of the tendon rupture now. Rather than treating the x-rays, you would want to discuss with the patient what his requirements and demands are and try to keep it as simple as possible and then deal with it.
Yes, as I'm a clubby of you, so same philosophy I used because he was property dealer and it was his left hand. So I removed the implant and then I did EI to EPL tendon transfer and did the salvage procedure for the DORJ.
Can I interrupt and make a quick point here?
Yeah.
So this is the point. So in an otherwise normal radius, this DRUJ in this cervic upon would have been okay. But when there is a volar angulation of the radius, the ulnar head is a little bit more dorsal than it should be in the lateral view. So I would rather have wanted it to be a little more volar. Second is, have you done anything for the proximal stump of the ulnar to stabilize it?
No, I have not done anything.
Okay, all right. But I think it's a very reasonable procedure to do, and this is perhaps the best that could have been done for it.
Thank you, sir. So I was able to get the supination, and second thing, he was not having the thumb extension. So by tendon transfer, I was able to achieve the extension at the IP joint of the thumb, and this is the retro position. So, any comment on this? Hope we have discussed all the things. Do anyone wants to comment at this stage?
I would like to put in a word.
Yeah.
We are stressing too much on the angulation of the radius and perfectly united fracture to again break it and get the right angles is a very difficult thing. And after 3 years, I don't think it's possible to reconstruct the DRUJ effectively. At least I have not been able to.
Absolutely. No, this was
the problem was really the prominent lower end of the ulna that was bothering him. Even the range of pronation supination was a fairly good range, I mean, functional range. So, I mean, we gained by doing this Sog the Panje procedure. But now you look at the cosmesis of the hand, it's looking perfectly fine. I don't think we would have invited more trouble by doing an osteotomy of the radius to my mind. I mean, it would have been much more difficult.
Absolutely, ma'am. I completely agree with you. What we were discussing was when the patient would have come maybe at around 3 months, 4 months, 6 months down the line.
But now this is 3 years.
Absolutely, 3 years. I wouldn't think of doing an osteotomy. But Amitji, there is one very important piece of information that we would like to learn from this patient. It would be very nice if you could assess this patient again and take some weight-bearing views, you holding a dumbbell to look for radio-ulnar convergence also, because that's something, we talk about it a lot theoretically, but I don't know how significant it is in the clinical situation. So please share with us at a later time how his proximal stump of the ulna is behaving, if that is causing any problem at all or not. It'll be a good learning experience. Thank you.
Because last time I saw when you took X-ray in mid-prone with weight bearing, and ulnar stump is just coming to radius, and at that in position he was having pain. So I started looking for these type of things. Correct. So certainly I will follow up and let you know.
Thank you very much. Thank you very much.
So I hope we are able to draw some conclusion that radial and ulnar height are quite important, and they should be restored, and even the bowing of the radius is quite important. So then only you can restore the forearm axis. So although these are the frequently encountered problems, and they can be missed, so just for getting the insight, we kept this session. Any comment? Rahul Garg sir, you want to say something? Sir, please unmute yourself. Please unmute yourself.
Doing my mistake actually, but still I would use this to my opportunity. That we were able to discuss so many take-home messages for routine practitioners as well as our younger colleagues. That how radial bowing is important, and as well as the length of the ulna. So two things are really paramount importance, that we should try and achieve 100% or reduce 100% to have distal and proximal joint stability.
So I will hand over to Dr. Rahul Katta sir for comments and.
So, thank you all the senior faculty members, especially Dr. Abhijeet for his pulse of wisdom for these common issues. Thank you, ma'am Patni, for your wiser comments on each and every cases and providing us some take-home messages with your experiences. All other panelists and faculty members who took part in the active discussions of these kind of problems. So apart from the take-home messages and technical details discussed by the masters, so what I have learned is there are three issues: what patient complains of, what you observe, and what X-ray tells us. So especially in each case, we should not treat the X-rays. We must treat the patient complaints first, and then our observations and the X-rays last in the chronic cases. So that is my learning for today. Thank you so much. From ROSA, we'll have such kind of webinars on regular intervals. I'd like to invite Dr. Arun Vaishya for his conclusive remarks as the president of ROSA.
Sir, please unmute yours.
Thank you, Rahul. It was a really wonderful webinar, and I would like to thank especially Dr. Abhijeet, Purnima, Patni Madam, Amit, Vyas, Vinit, and everybody, all faculty members who have given their inputs on forearm fractures. Really, we all have learned so many things today, and we are very grateful to all the panelists who have taken active participation, and we would like to see more of such activities and webinars in future. Thank you very much once again. Hope to see you soon. Stay safe, stay healthy.
Thank you. Thank you very much indeed. It's been an honor. Thank you, madam. Thank you, everybody. Thank you, sir. Thank you.
Thank you.
Thank you, sir.
Thank you, OrthoTV, for providing us the platform for today's webinar. Thank you.
Yeah, OrthoTV. Thank you.
Thank you.
Stay safe.
Bye. Stay safe.
Neeraj, are you here?